Excisional Goniectomy with Kahook Dual Blade. MIGS devices and procedures are preferred as they are minimally traumatic, much quicker, with a high safety profile, and rapid visual rehabilitation, which impacts a patient's quality of life. However, for this, a new skill has to be acquired. Unlike trabeculectomy, which creates a subconjunctival filter, MIGS follow physiological pathways quite like topical medications, targeting the trabecular meshwork, suprachoroidal space, and the ciliary epithelium. For this purpose, the new skill to be acquired is that of intraoperative gonioscopy to visualize the trabecular meshwork. Although there are many MIGS devices and procedures, only a limited number are available in India, one of which is the Kahook Dual Blade, which is designed to achieve near complete removal of trabecular meshwork with minimal surrounding tissue damage. It has a sharp tip, a ramp that stretches the TM, dual blades that cut it very precisely along with the inner wall of the Schlemm's canal, unroofing it, and a heel that fits in the Schlemm's canal, preventing collateral damage to the outer wall of the Schlemm's canal. Seen here are examples of precisely excised trabecular meshwork. There are several preoperative considerations. Angle has to be open on gonioscopy and cornea clear. It is particularly useful in secondary open-angle glaucoma like pseudoexfoliation, pigmentary angle recession glaucoma. Usually effective in mild to moderate glaucoma, decided by visual field criterion with an eye on target IOP. If PAS is present in angle, then relatively clear areas can be targeted in intermittent PAS, or else intraoperative goniosynucleolysis has to be planned. If sparse pigment is present in trabecular meshwork, then sometimes blood reflex into Schlemm's canal will make it stand out as a red line, or you can plan for intraoperative trypan blue, as seen here. One of the most important preoperative consideration is to manage patient expectations. This cannot be stressed any less. Where anesthesia is concerned, peribulbar if one is just starting, or subtenons, topical can also be attempted after a little experience. Before attempting the first MIGS, one must always practice intraoperative gonioscopy under high magnification at the end of routine phaco cases. One must learn to create clear corneal wounds so that bleeding on the surface does not interfere with the coupling gel, making gonioscopic view hazy. And one must learn to avoid corneal striae with too much pressure on the gonioprism, or avoid air bubbles with too little. The surgical steps involve positioning of the operating bed first into a reverse Trendelenburg position. The surgeon needs to sit temporally, and a clear corneal incision is made, avoiding blood vessels. The microscope is then tilted at least 35 degrees towards the surgeon. I have it pre-marked on all the microscopes I work on. Following this, the patient's head is tilted at least 35 degrees away from the surgeon. A cohesive viscoelastic is then placed over the cornea as a coupling gel for the intraoperative gonioscopic lens. There are multiple techniques of goniectomy that have been proposed: inside out, outside in, and the mark and meet. However, there is no best technique. Once there is off-face view of the trabecular meshwork, it can be excised. Here in this case, it is being done prior to cataract surgery. My preferred technique is excision in a straight sweep, and the excised trabecular meshwork is then removed with micro graspers. A little regurgitation of blood from Schlemm's canal is a welcome sign as it confirms its unroofing. Here, an inside-out technique of goniectomy was followed. And unroofed Schlemm's canal are seen here in a few post-operative gonioscopy photographs. There are a few pros and cons of doing angle MIGS either before or after cataract surgery. When done after cataract surgery, then angle is open wider and there is no risk of accidental nick of the capsule. However, when done after extraction of a dense nucleus, corneal edema may compromise view of the angle and positioning of the patient may lead to overflow of fluid onto the surgical field. The advantage of doing it before cataract surgery is that of a closed chamber, as it can be done just with a temporal paracentesis, and of course corneal clarity is good. Doing it before, one may find that the angle may not be as widely open. Regurgitated blood from the Schlemm's canal may obscure view for rhexis, and accidental damage to the anterior capsule may compromise phaco. However, one will always be apprehensive about phakic standalone MIGS procedure if one does not attempt MIGS before cataract surgery. As seen in this phakic case, where it is being done as a standalone procedure in uncontrolled angle recession glaucoma. Of course, one has to be very mindful of the anatomy in such cases. This patient's IOP reduced from 45 on 5 topical drugs to 17 on 2. When peripheral anterior synecdoche is present in the angle, then goniosynecdolysis can be done with a blunt instrument like an iris repositor, and then one can proceed with KDB. The post-operative follow-up is quite like phaco, as visual recovery is more or less similar. Day 1, week 1, month 1, unless of course hyphema occurs or it is done post-goniosynecdolysis when patients can be followed up much closer. Topical steroids in tapering dose for 4 weeks are given, but one must be wary of a steroid response. Topical antibiotics for 1 week and NSAIDs can be used as per requirement. Use of pilocarpine helps when goniosynecdolysis is done. One can stop all preoperative topical medications in mild to moderate glaucoma and reintroduce as per need. Complications that have been reported and that I have seen so far are a transient spike in IOP, mostly at week 1, transient microhyphema, pigment deposition on unroofed Schlemm's canal, and a new goniosynecdoche or peripheral anterior synecdoche formation. So far, I have not had to do any redo surgery. Several authors have reported KDB success in varying etiologies of glaucoma, and in a review it was found that mean IOP reductions of up to 36% and mean glaucoma medication reduction of up to 92% can be achieved in standalone procedures. When it is combined with cataract surgery, up to 34% and 79% of IOP and medication reduction have been reported. My own data, so far unpublished in phaco-KDB in eyes with mild to moderate glaucoma, has revealed approximately 30% reduction in IOP and greater than 90% reduction in topical medications. Here's a case scenario of a 74-year-old lady who was very intolerant to all medications, including preservative free, with constant complaints of teary, watery red eyes, who had moderately severe OSD in POAG and cataract with an IOP of 24 on 2 drugs. After a year's follow up following phaco-KDP, IOP reduced to 11 on 0 medication, BCVA being 6.6 and 6. But the need of the hour really is in advanced glaucoma. Reduction of aqueous, that is inflow with endocyclophotocoagulation, and enhancement of outflow with either KDB, iStent, or some such has a synergistic effect, quite like some fixed combination topical medications. And this helps to reduce IOP and AGM in advanced glaucoma also. Such an approach has resulted in 42% reduction in IOP and 80% reduction in topical medication in unpublished data so far, and there has been no serious sight-threatening complications. As illustrated by this case of a very severe one-eyed glaucoma patient with bronchial asthma and 2 failed previous filtration procedures. He had phaco-KDB and ECP, and after 1 year of follow-up, uncorrected visual acuity was 6.9 with an IOP on 12 on pilocar, which was continued to prevent synecdoche formation. To summarize, there are only limited number of MIGS available in India, but unlike trab and tubes, they utilize natural pathways. It is quite efficacious in reduction of IOP and reduces or eliminates topical medication as well, resetting a patient's AGM clock. It is very safe and preserves the conjunctiva. It is easily combined with cataract surgery, and it can also be combined with ECP, where it appears to be efficacious and safe in advanced glaucoma also. MIGS, in my opinion, should be offered to all glaucoma patients undergoing cataract surgery, especially when there is AGM intolerance, allergy, compliance, and adherence issues. Thank you.